Amazing.
Perfect. All right. Good morning, everybody. My name is Blair, as Dr. Zelentsov mentioned. Thanks so much for joining us today. I am the perfusionist assistant here at the New Brunswick Heart Center. And Mackenzie's not joining me physically, but he was a big helper in terms of creating this presentation. And so we'll definitely give him the credit. So I will preface this with a couple things just before we begin. Obviously, the stats dinner and the mini symposium coming up this weekend. Very excited for those two events and looking forward to seeing a lot of you there. Additionally, you'll notice in this presentation that there are some patients or patient identifiers. Those have all been obtained rather with the consent of the patients. So don't be too alarmed. I promise I'm not breaching any protocols. And other than that, there's just a short video clip. This will not be a crazy in-depth rounds. This is sort of just a general overview of our services that the perfusion department provides. And hopefully you guys enjoy it, and hopefully we have a little bit of fun along the way. So perfusion services, NB Heart Center's perfusion team, a little bit of history. The Heart Center Perfusion Department was established in 1991. Originally, it was made of 4 members who were all perfusionists at the time. And now we're up to 8, which is pretty exciting. We've duplicated, which is great. Services are obviously expanding. The field is constantly evolving. Procedures are changing all the time. And even the technology and the surgeons themselves are differing. And that's exciting because that kind of makes our job interesting and the services that we provide unique. So the squad, this is our group. We're managed by Steve Cheney. You'll notice a fun little video clip of him later. We've got Ron, Glenn, David, Michaela, Chris, Mackenzie, and Amy. And if you see any of us around, I promise we're friendly. And just say hello and say, hey, you're wearing the cool hat, or you look like you're a perfusionist. So what's going on? What can you tell me? I'm the assistant. It's kind of a newer role in the past few years, one that's kind of developed into a new scope. And basically, I am not a perfusionist. I am an RN. And it's important to know that I cannot perfuse the patient. So we've got a little video clip. I hope you enjoy it. Hopefully, we've got a few fans of the office here. We'll just watch this, just a 30-second clip. So that little clip, that's us. I know you couldn't see our faces a whole lot, but you'll be able to see a lot of equipment that I'm going to display here in this presentation. So the first service that we provide, and definitely the most common, kind of our home turf, familiar old bread and butter, is Cardiopulmonary Bypass, or CPB. You'll see it abbreviated a lot. And essentially during cardiopulmonary bypass, we operate and maintain the heart-lung machine for the purpose of achieving bypass, and that is definitely our primary service. What does that mean? Well, that means that we're managing the patient's blood volume and hemodynamics throughout the case, arresting the heart for the purpose of the surgeon to perform the operation, and obviously reanimating the heart ideally upon completion of the procedure. And definitely nothing happens that we do on an island. We're heavily involved with anesthesiology team, nursing team, and surgical team to accomplish all of these tasks, actually, but definitely cardiopulmonary bypass. It is absolutely extremely collaborative. And so that's really exciting. Draining the patient's blood volume, ensuring adequate blood flow and oxygenation, and safely returning optimized blood to the patient, bypassing the heart and lungs. Just for a fun little stat, this is a brief stat. Don't worry, you got to come to the stats dinner if you haven't signed up already. I think they may be full, but if not, talk to Nancy. We perform around 900 cases annually, and we were just about reached that number last year. So that's super incredible, really. This is a heart-lung machine. Let me just see if I can pop up a laser pointer here. This is sort of the area that you'll notice the patient's blood is coming into. We've got the reservoir coming into the cone, into the oxygenator, and then it comes through our system back to the patient. Over here is the cardioplegia. That's the one that stops the heart that we were talking about. Little flow meter that basically enables the flow to be changed to the patient. These are all just sort of monitoring devices of different kinds and alarms. This is our charting system. And then we have pump suckers and a vent here that we typically use along with the procedure. And again, this is a brief overview. It'd be fun someday with rounds to go sort of in depth into all of these services, but we're just trying to reach a surface level understanding of the perfusion services here at the NB Heart Center. So cardiac procedures that we would participate with the cardiopulmonary bypass are the following: coronary artery bypass grafts or CABGs, valve repairs, replacements. We have repaired and replaced all 4. Sometimes we do 2 to 3 in one operation. Combo cases, which is grafts and the repair or replacement of a valve. Aortic repairs, root ascending arch repairs, and often some combination of the 3 components. We also are heavily involved with the hypothermic circulatory arrest cases, which is where we severely cool the patient and make sure that the blood flow to the brain is adequate, but essentially the rest of the circulation has arrested. Myectomies, pericardectomies, and of course emergencies, which could be any of these things in the emergent environment. Cell savers, that's our number 2, probably our second most common service that we provide. And of course, it's the operation and maintenance of the cell-saving methods, which we have. We have 2 of them. The autolog, which is sort of your average 135 mil bowl, standard surgical case guy, and then the extra, which is the large volume 225 mil bowl. We'd probably use that one in a bit more of a maybe a redo or a revision, typically a larger aortic case. And speaking of which, we do these services right now for the cardiac, orthopedic, vascular cases. And actually, we've been involved in the neuro field a little more recently than in the past with spinal fusions in the cervical region. We performed over 750 cell-saving procedures last year. Again, shout out to the stats dinner. We'll get the true numbers then. And what we do, what is a cell saver? That sounds cool, but what is it actually? It is taking whole blood or lost volume from the patient, or that would otherwise be lost, washing the volume of any products, factors, etc., and then just getting those RBCs back to the patient. And this is huge because it avoids and reduces transfusion and associated risks mainly, but it also helps really reduce costs operatively for the patient. These are our cell savers on the left here. We've got our autolog, that's sort of our smaller guy that we use much more frequently. And then the extra is this big fella over here. And that's the big 225 mil bowl. And this one can go into a very rapid emergent mode where essentially as fast as the blood is coming off, it can be washed and reinfused to the patient with a few other factors to consider for sure. TAVI support and standby is another service we provide. So transaortic valve insertion procedures are performed scheduled Mondays and Fridays typically at the New Brunswick Heart Center. And I'd say we average about 4 weekly, and we performed about 200 last year, probably a little bit more than that actually. During this, what do we do in this situation? Well, we have a heart-lung machine on standby with a modified setup in the event that additional support is required. What does that mean? That would be like pressure management situations where the patient is just unable to come away from the pacemaker where the valve is deployed. Sometimes, very rarely, there is dissection episodes as well. But the best part, in my opinion, about TAVI support and standby is it's very intercollaborative, very interdepartmental. We have interventional cardiologists, cardiac surgeons, our team, cath lab team, interventional team. It's a great time to sort of interact with all the different departments and collaboratively improve patient outcomes. This is us in our corner at the cath lab on TAVI standby. You can see here that's that heart-lung machine we saw earlier. And this is sort of the surgical team and the physician team up at the table. And then we have our interventional team. This nursing team would be on this side. And like I say, it's just a great interdepartmental situation. ECMO, the big one. We have 2 distinct types that we can offer. Veno-arterial, which is utilized typically when there are problems with an individual's heart and lungs, and veno-venous when there is usually just an insult to the patient's lungs. We do provide ECMO coverage, of course, to the entire heart center / regional hospital. But there is also an aspect of we are providing a provincial-wide ECMO coverage just because we do have a transport team and some protocols in place to deal with that. That is constantly developing and evolving. So that is an interesting field, and it's actually something I'm going to be talking about towards the end in terms of future endeavors. Again, patient consent was absolutely obtained for this photo. This is an ECMO transport. You can actually see here, we have our lines coming venous and arterially coming into the cardio help system here. And this is actually how compact we can get our setup right here, which is great. This is a fully functioning ECMO system. We've got an O2 here, and I believe this patient had a balloon pump off camera here, but this is a chest tube, drainage, and a Foley, of course. That's kind of how nice we can get our compact setup for interprovincial transportation. Balloon pumps. So intra-aortic balloon pumps are definitely a common one for us as well. They provide afterload reduction, increased coronary blood flow through the augmented diastolic pressure. And we cover the cath lab, ICUs, cardiac ORs. And we have had to transport patients with balloon pumps as well. And you would have seen David actually and Ron, in the video, they were both working on a balloon pump module. So that's what it looks like there. And it's kind of a nice little grab and go setup. And we have a variety of balloons that can be inserted into the patient and hopefully support them adequately during the procedure. PCI support, speaking of support and standby. So during percutaneous coronary interventions, multiple supportive adjuncts are utilized in the holistic care of the patients. We talked about VA ECMO, which would be one that we do a little bit less common, but is becoming a little bit more frequent, which is great. Balloon pumps, as we just discussed. And then we have an Impella VAD service, which is great. So a VAD is a ventricular assist device, and it's specifically for left-sided heart support. And it transports blood directly from the LV to the ascending aorta across the aortic valve, which might sound funny because obviously that's just the natural blood flow pattern, but it really helps assist that left side and really increase positive patient outcomes. So this is a classic PCI circuit that we would have for an ECMO setup to support a patient receiving a PCI. And so this is just a modified setup. You remember our heart-lung machine was a bit large, and so obviously it's not ideal for a cath lab situation aside from the TAVI setup. So this is just more of a sleeker profile, but still the oxygenator is here, the cone is here, and we would connect the sash to the patient and just help manage flow, pressure, and make sure that they're receiving the positive outcomes that they need. VADs, so ventricular assist devices, these are the ones that we sort of just went briefly over in terms of the Impella, but that one is a left heart function VAD, which is great. We also have a Protec cannula, which allows for us to essentially create a temporary RVAD, so a right-sided ventricular assist device, takes blood from the RV and puts it into the pulmonary artery, which is excellent. We just have had a couple folks actually who have needed RVADs. LVADs, same thing, but on the left-hand side. The Impella is sort of a modified LVAD, but it is still an LVAD. And then we can actually do both. So this is a quadruple cannulation situation where you would have a cannula taking the blood from the RV and bringing it up into the PA, and then you also have two more cannulas that are taking blood from the LV and bringing that right into the ascending aorta, helping both ventricles to get some rest and relaxation and hopefully regenerate appropriately. This is an RVAD setup. This is our gentleman, Mackenzie, who we talked about earlier. He is supporting this patient here. Again, this was obtained with his consent. This is the cannulation that is coming across and going into the neck of the patient here. And as it comes off, this is our sort of modified RVAD setup over here, which is controlling his flow and helping his right side of his heart, like I say, to just receive some relaxation, regenerate, and take a lot of that workload off. This is a physio who we would come in, and this patient would actually ambulate a significant distance, of course, with the help of the whole team, because there's a lot to walk with, but he had an excellent recovery and was eventually discharged. Angiovac, this is a cool one, especially in terms of pictures. It is a service that we offer that removes vegetation and or thrombi, typically from the tricuspid valve. It's often because of endocarditis or cardiac emboli that this vegetation is present at all on the valve. We have performed it in interventional, and it's an excellent option for non-surgical candidates or people who are at risk for eventual surgery, but perhaps we can give them some more time to not have to go to the OR. So this is really neat. This is the vegetation filter of the Angiovac, and as you can see here, we've got some nice, I won't call them juicy, but large vegetations that we've been able to take off that valve. And as you can imagine, if your valve had that on before, I'm sure it would feel excellent after. Renal perfusion is one that we've been a little more frequent with as well, which is great. When the descending aortic aneurysms are being repaired by vascular, if the aneurysm is above the height of the renal arteries, the aorta needs to be clamped above the renal arteries to remove the aneurysm. So obviously that restricts blood flow significantly to the renal arteries and to the kidneys. So renal perfusion is a system where we perfuse directly down the renal arteries. The vascular surgeon will take a little tiny catheter, he'll plug that into the renal artery, and then we'll infuse a solution that keeps the kidneys cool and protected. And it's not much to look at, but this is essentially a large ice bucket. We've got a Quest. This is actually a cardioplegia device that we use to infuse the renal protective solution, which can be found here. And we do that often in vascular, again, when the aneurysm is above the height of the renal arteries. ROTEM and TAG analytics are also a big one. This is almost every other case, if not every case for sure. Operative cases of blood samples collected, and we can provide sort of an analysis of necessary coagulation products that may be required as the patient comes off bypass or perhaps during a long case. And also we run a lot of blood gases during the case, but we do the occasional ones from the cath lab and other ORs in the main OR as well that require a little more intense monitoring just because of comorbidities or other ongoing developing situations. And future endeavors, so those are kind of all the main services that we provide right now. And we love to provide them, and we're very happy to. So hit us up anytime if you are interested or you need to talk to us about those services. For future endeavors, we thought this would be interesting to include because we are in the works for developing a durable VAD program. So back when we were talking about the right-sided ventricular assist devices and the left-sided ventricular assist devices, those are temporary measures. And unfortunately, if patients require those devices in the longer term, if they're a transplant candidate, they'll have to go to Halifax or even further. So that is okay, but it's not ideal. And we are in the works of developing a durable VAD program. I'm sure the cardiac surgery team would be able to detail that much further. I just know that it's in the works and we'll be heavily involved with that. And then actually, mobile ECMO services, we are in we have the capacity, I guess, to have our transport team, but a super ultra portable mobile ECMO service would be really ideal for out of hospital cardiac arrests. And we would like to work towards that as well. One of our perfusionists, David, just came back from a conference in America, in the States, and they showed a Minneapolis-based service where a large bus, was able to go to a tertiary facility, implement ECMO services, cannulate a patient, and bring them to a central ECMO ICU for monitoring. And just because their services were so portable and so compact, it was really, really interesting to see that. And David was kind enough to share that information. And a system like that would be really interesting. And I think it probably is the way of the future. I have very little experience in understanding that, but I think that seems to be the trend. And I would be really excited to sort of further look into that field. In a general summary, like I said, it's going to be pretty brief today, but as a department, we definitely love to have fun. We provide directly beneficial services, as I've just discussed, to our patient population. And we also enjoy continually learning and growing. And I just want to say thank you to everybody. This is a nice little picture of our equipment room, which is, as you can see, busy because of the services that we provide. But we love it and it's fun. And like I say, if you have any questions, feel free to ask them. I'm happy to answer them. I do have an actual perfusionist with me as well who can answer questions a little more in depth. So thank you guys very much.
Blair, thanks for the talk. I think it really highlights the large breadth of services that you guys provide. It's impressive. And I think the part that you didn't mention is that for often weeks, sometimes months at a time, when we have multiple people on ECMO, the perfusion team sleeps in-house for literally weeks and sometimes months at a time, and is still pumping cases the next day. So an incredibly hardworking, adaptable group. And we have you guys to thank for a lot of our successes. So thanks for highlighting all that.
Thank you, Dr. White. I appreciate that very much. That's absolutely true. And shout out to the NB Heart Center for we have a nice little call room upstairs now for that, which is excellent compared to our previous locker room situation. So very thankful for that.
Thank you so much again for your presentation. There is a question from the chat. How often do you see impellers in the cath lab?
Oh, okay, perfect. Tashina, how often would you say we see impellers in the cath lab? I would say, yeah. It is a new service, particularly with Dr. Hubacek that we've been doing. I would say we're probably at definitely one a month-ish. Yeah. Yeah, so Chris Fallow was just mentioning that we've done one so far, but there have been a couple cases where it's two so far, but there's been a couple cases where we've been on standby just in case. So I'd say we're probably averaging about once a month just since the program has started.
And just by a bit of background, for a couple year period, we went without Impella. It was just more of a kind of cost utilization decision. But as the number of complex PCIs requiring mechanical support have increased, we have the Impella back again for that indication. And each patient, we have a multidisciplinary discussion about whether we feel ECMO support or Impella support is most appropriate. And there's a variety of factors that go into that decision. And then we choose whichever pump device we feel is most suitable for that patient. And I think the number of mechanically assisted PCIs we've done in the last, 4 years or so is, probably up and around the 30 range or so now. So it's a combination of ECMO support and Impella support for those people.
Okay, thank you. Any other questions?
No, thank you, Blair. This was amazing. Nice overview.
Thank you very much. Very happy to do so.
Thank you.
Thank you so much. And once again, I wanted to remind everyone about the symposium this Saturday. Please attend. Okay, thank you and have a great day.